Good afternoon, everyone, and thank you for joining us for the Behavioral Health Across the Care Continuum panel. We have a great panel today, and they come from all over the United States and represent all different aspects of the healthcare continuum. As you all know, there's been a need for healthcare organizations to address behavioral health concerns, and the pandemic has placed a strain on these services to the extent that it's been placed front and center. At this point, we're really just looking for all ways that we can to continue to extend the reach of behavioral health networks and to really reach patients where they are. And so today, I want to introduce our panel today. We have five fantastic panelists. I'm going to let them introduce themselves in reverse alphabetical order by last name. I will say that our second panelist, John Mackenzie, is having some technical difficulties. So if for some reason he drops, I will introduce him, and we'll hope that he is able to rejoin us during the broadcast here. So, Anne, I'll let you start.
Thank you. I'm Ann Posey. I'm the Director of Behavioral Health Services with Cleveland Clinic Indian River Hospital. We're a 46-bed inpatient Baker Act receiving facility in Florida, and we also work with the rest of the Cleveland Clinic system in Florida, which consists of about 5 emergency rooms and also medical hospitals where we use telepsychiatry to do consultation.
Yeah, thank you very much. My name is John Mackenzie. I am the Clinical Program Manager for the Dignity Health Telemedicine Network, and we currently service facilities in California, Nevada, Arizona, and Hawaii. Basically, about 24 facilities across all of those states, providing acute and consult liaison services as necessary.
Fantastic. Next, we'll go to Jana.
Hi, everyone. I am Jana Capaccio with Horizon Health Services. I am the Director of Clinical Implementation. We are located in Western New York, and we have about 20 different locations. We provide substance use and mental health services, and we also have a residential services program.
Excellent. Next, Katie.
Hi, I'm Katie Akimoto. I'm with Hawaii Medical Service Association, the Blue Cross Blue Shield in Hawaii. I'm Senior Vice President of Health Management, which in our health plan oversees most of the clinical operations for the organization.
Well, wonderful. And to introduce myself, I'm Anthony Sasong. I'm the Chief Medical Director for Behavioral Health at Amwell, and I'm looking forward to having this discussion today. I think what maybe we can do is just to talk a little bit about the different programs that you all are running, and just hear a little bit about how things have been over the last year. Maybe we'll reverse that order and start with Katie. At HMSA, you've onboarded a huge amount of network behavioral health providers in response to the pandemic. Can you talk about the importance of focusing on this aspect of your telehealth program and what the impact's been for your members?
Thank you, Tony. Hawaii is a unique island state. Many people on our neighboring islands have to fly to Oahu for specialty care. So when the state enacted its safer at home emergency order, our inter-island airlines also shut down. So we had to really do something different, since most of our providers are independent practices or in very small medical groups. So they didn't have the infrastructure to provide virtual visits. So HMSA's online care that's powered by Amwell was critical to people getting access to behavioral health services. So we all know that behavioral health is vital to a healthier community. So now our members have access in a safe, private, and convenient way. Prior to the pandemic, we actually had 75 to 85% of our visits already in the behavioral health category. So we were well ahead of the game. But in 2020, we actually quadrupled the number of visits on our platform. So we had to reach out to hundreds of our provider network, and we were able to onboard 400 new behavioral health providers and over 53,000 members. Now, for some of you, that may seem like small numbers, but in a state with a population of only about 1.5 million people, those are significant. So we were very proud to offer online care for our members, providers, and the community in the state of Hawaii.
Wow, that's fantastic, and really all over the last 18 months. Yeah, so I think we have a lot to learn from your implementation, and I think one of the things I'd love to come back to with everyone, Katie, especially with your rollout, is lessons learned, and just to hear how it is that you quadruple your providers and change the entire way of doing business. So we'll definitely come back and talk a little bit about that. So going in this reverse order, Jana, I'm really interested in hearing from you. That Horizon Health Services has scheduled virtual visits between existing patients and providers, and I was wondering if you could walk us through the use case and the effect it's had on patients.
So yeah, we were very fortunate to go live. So we chose 5 of our outpatient clinics prior to the pandemic, and we went live with those clinics with telehealth services in November of 2019. So we had, developed training materials for staff and patients, had trained some of our providers, clinicians, as well as support staff for those sites. So when the pandemic hit, all we really had to do, but thankfully we had already created all those materials. We had a platform, and then in a very short period of time, we brought on about 400 more providers. So very similar to what Katie was saying. And we then started bringing, our patients on the platform, kind of walking them through the process, how to complete the enrollment, how to connect to the visits. Also, creating some training documents for them, right? Because I think that was the other thing that we found was challenging sometimes, having our clinicians kind of walk the patients through maybe on the other end and sharing with them, what does your screen look like? So yeah, our telehealth services just skyrocketed and have continued to increase on a week-to-week basis.
So huge growth also for your organization. And
yes.
What's really neat to hear is that you built on the in-person relationship between doctor and patient, and then grew that to include telehealth, and then from there grew the service. So again, I can't wait to hear some of the lessons learned and the anticipated, unanticipated issues and solutions. So okay, up to John. So John, Dignity Health is using APC in both the ED and ambulatory settings. Hoping you could tell us a little bit about the impact virtual care's had in really both of these settings for acute behavioral health patients. And one other thing that you had mentioned when we talked before was that the recent APC joint commission accreditation had some unanticipated benefits too. So I'd love to hear what the thoughts are on that.
Absolutely, yeah, thank you. Well, having access to 24/7 psychiatry prior to the pandemic, because we're kind of talking about that, the impact of that, we've been using APC for a long period of time. And prior to the pandemic, it was almost seen as an add-on service. However, during the pandemic, everybody became much more comfortable with telemedicine, telehealth, and already having a full service 24/7 product that was available really just enabled us to take advantage of the large use cases that everybody else, that we'd been doing for a while, but everybody else just came on board with. And so we did see our numbers kind of maintain where a lot of other services dropped. So being able to have the ability to reach into the emergency departments remotely not having psychiatrists have to come in person and potentially expose themselves or patients or otherwise really made a huge impact. And the Joint Commission addition to the service really helps us with things like credentialing, being able to speed up the credentialing process, using APC as a hub really is just a dynamic component that a lot of people don't realize. There are very few telehealth providers that are fully Joint Commission accredited. So we were happy to be able to participate in that and enable that process to happen. And we're looking forward now to really reaping the benefits as a customer of the product to be able to speed up credentialing and also have that gold standard approach to quality, to provider services, and everything that comes along with the expectations of the accreditation.
That's great, and so helpful to hear how, you know, we often think about ambulatory care as being the real safety net and or the first line for patients, and there is spillover to the ED, and there certainly has been during COVID. And so it is really interesting to hear how telemedicine has been helpful both for first line treatment in the outpatient setting and for that spillover in a more acute setting that provides that sort of community safety net. So great to hear, and thanks for the feedback on the Joint Commission accreditation. That's really helpful. Certainly, it's something that we're proud of, and it's a real indicator of the quality that we are continue to strive to. So up to Anne. Very interesting. Can you talk about the impact that Cleveland Clinic Indian River hospitals seen around acute behavioral health response times, transfer rates, and I know clinical satisfaction has been another metric you've used to track progress. And what's the implementation of APC, ambulatory psychiatric care, in the ER really done for those metrics?
So it's been invaluable to us. During the pandemic, interestingly, while we saw a decrease in ER visits across the board, we saw an increase in behavioral health visits by about 2 or 3%. So we were seeing more behavioral health patients than we've been seeing previously. Bed situations became very critical. A lot of our providers reduced the number of beds. And so we needed to be able to triage people very quickly in the emergency department to determine if they truly did need to be inpatient or if there was a less restrictive level of care. Prior to our relationship with telepsychiatry, even before the pandemic, we had about a 24-hour turnaround for psychiatric consults, and they were done kind of boots on the ground. So the doctor would have to go to the emergency room or to the floor and see the patient. We've gone from doing maybe 100 telepsych visits a month to almost 220 a month, as well as taking our response time down from 24 hours to about 40 minutes, and which has been a huge satisfier. As we've expanded, we originally started with just Indian River Hospital, and our sister hospitals had a different telepsychiatry company, to be honest. And when we were able to join the same panel, it made the ease of admissions and transfers from those EDs so much easier. Our providers here know the telepsych providers, and they trust them, and they knew that the assessments they were getting, you know, would meet the criteria for inpatient placement. So it's really smooth. That we do about 600 transfers a year from our sister hospitals, and that has really helped speed that process up. We're very attuned to the emergency department and making sure their throughput times, you know, that patients are boarding in the ED for long periods of time. So we've seen a great benefit with it. And we had a very interesting thing during COVID. So we have a pediatric psychiatric ward here, or unit here. We admit pediatrics, but we do not have a pediatric medical floor. So when we get a COVID positive child who needs inpatient psychiatric care, we have to admit them to a sister hospital, and then we need to provide psychiatric overlay to that child while they're in that hospital. And the telepsych process has made us able to do that seamlessly.
So I'm always struck by this. Last time you mentioned it, it was just as jarring that you have that inpatient subspecialty service for pediatric psychiatry. I mean, that's just such a blessing. But like you said, there across the board there was a reduction in beds. I mean, by necessity, not just for staffing reasons, but for social distancing reasons and other infection control concerns. So it sounds like you all have been able to really pivot, and that the consolidation of telehealth to one organization has helped with that focus on transitions that really is the mortar that connects the important bricks of the treatment. So I'm just again struck by just how comprehensive and varied the story is across all of you four here. I mean, we're talking about from Katie at a state-based population health level and thinking about rollout for an entire state during the crisis, to the acute setting, outpatient transitions. We really have a good picture of just how challenging this has been. So before we talk about lessons learned, which I think is the kind of thing that very likely we'll get questions about, I do want to see if we have had any questions come up from the audience that we want to address. Yeah. So are you integrated with an EMR? And if so, are group therapy sessions hosted via the EMR AMWell connection? If yes to both, were there any challenges? Anne, let's hear from you.
So from an inpatient setting, our telepsychiatrists are fully integrated into our electronic medical record. They can document in the record, they can give admission orders, they can write medications, and they can act as if they were the boots on the ground doctor in the EMR, which is very, very helpful to our providers. So they are, from an inpatient standpoint, fully integrated into our EMR.
Great. And just to transition again to the lessons learned, were there any surprises in sort of how you addressed telehealth, documented, did some of the billing under the, this intense transition?
Lessons learned, I really think communicate. That's one of the things that is very important. There was some implicit bias, I think, originally when we rolled out telepsychiatry. People would say, I want to see a real doctor. And we had to do a lot of education. I do think one of the gifts that we've seen is that telehealth is becoming much, much more acceptable, and that we've been able to leverage that through the pandemic.
I think for us, so we are not integrated with our EHR. And I think one of our lessons learned was that there is a lot of administrative burden, right? The duplication of scheduling and really having systems in place and staff in place to be able to help assist with that. And then we actually ended up hiring a virtual technical assistant to do some outreach to the patients to help them with enrollment, help troubleshoot with technology. Because what we were finding early on is that the clinicians were spending their time sort of doing the troubleshooting, and that's really, they're there to do therapy with the patient. So since we've brought her on board, that has really helped. And it's really, allowed the clinicians to focus on doing clinical work.
Thanks, Jana. And I think my video may have frozen again, but I'll pitch the same question back out to John and then rejoin. John, with Dignity, what was your experience with documentation in the EHR?
Well, we because we had a well-established process and APC has full access to our local EHR, the pandemic itself didn't have a negative impact, but it did enable us to again keep providers out of the facility that didn't need to be in the facility, and we are able to get direct access, review notes prior to seeing patients, perform that interaction with the patients, provide the communication link with on-site staff, and then again, for facilities that have an inpatient unit, again, go ahead and just drop those admission notes directly into there and have that patient seamlessly transitioned to, quote unquote, upstairs. So the satisfiers are amazing because ED providers can directly reach a psychiatrist. We can be at the bedside within 30 minutes and then see the patient, drop in their admission notes, and just have them, go directly to the appropriate level of care. So it's been very good.
That's really helpful to hear. And it does seem like in all of your cases so far, it's been a matter of coordination of care, whether that's administrative coordination and documentation, coordination for the patient. These have all been the challenges to overcome. Katie, I'm curious if you'd like to share with us some of the lessons learned or the surprises, perhaps.
So our big surprise was trying to onboard all these providers and members like in 5 minutes. Like Jana was saying, they need education. Providers aren't trained to enroll members into online care. And this in the middle of the pandemic when our entire workforce has just been sent home, some a little unprepared to work from home. But we're really proud of our staff. We put a call out to all of our employees to volunteer to get on the phone, get online, help empty email boxes to help our members enroll. And it was really impressive. I mean, this along with, I'm sure, everybody else's challenges, Amwell itself was 750 times the number of visits and the number of inquiries. So that was kind of the real eye opener for us, that as technology has progressed and everybody's on social media and screen time, people still need help. And sometimes it does take a person to help those people get the care that they need.
That's great. And I remember you mentioned digital literacy as a sort of a topic was the real focus of a lot of the education. And it sounds like, that's for providers and patients and really everyone across the board, really a major part of the success of the program. The other thing I wanted to ask before we move on and talk a little bit, we have one more question from the audience we can talk about. But one of the things you had been doing pre-COVID was to really focus on onboarding behavioral health providers. And that pre-COVID work obviously turned into a fire drill once COVID started. What was the difference in how recruiting, onboarding, and sort of processing that volume of folks? How was it before COVID and during COVID, and what would you say to somebody who had to do that kind of onboarding now?
Well, HMSA was Amwell's first health plan customer 11 years ago. And back then, it wasn't totally embraced in Hawaii by those physicians who really believe, laying on of hands is like so important. So we were fortunate in that we had a few lean forward behavioral health providers who actually converted their brick and mortar practices to virtual visits. And that enabled them to expand their practice across all of the islands, have conversations with primary care physicians for immediate referrals. And I think now that we've gone through COVID and many people have almost been forced into these virtual visits, more behavioral health providers, APRNs, licensed social workers have moved their practices into this virtual environment, and we think that they're going to continue in the long run.
That's great. And I know that all of you have been really focused on augmenting the behavioral health sort of resources, availability, access across the board. I'd love to hear from the rest of you about your efforts pre-COVID and during COVID, and also think about where do you see the most potential for virtual behavioral health outside of what you're currently doing, and what are the ways in which Amwell Solutions can allow you to deliver that, on those goals?
One of the things that we did when we trained all of our providers that was helpful, I hope, was I actually ended up we ended up doing test sessions with all the providers just as part of our clinical training. So it was the training, and then I played the patient and they were their provider just to get them comfortable on the platform, right? Because it's things like hitting the reload button. How do you end the session? How to use the chat? So I think many of them found that helpful once they were done with the training, right? Because I think that's oftentimes just the doing something new that you haven't done before, right? So if we can just get people comfortable in a system, I think that really helped. And then we ended up having just refresher trainings too. Like if somebody maybe didn't do a whole lot of services after the initial training, we just kept offering trainings for people to be able to attend. And then kind of going back to the question, one of the potential services, that we can utilize more with telehealth, I think family visits, right? Many of our patients historically, we would have them in session and then maybe mom lived in Hawaii, right? And we could never bring her into the session with us. We would maybe have her on the phone. So just being able to do some more family work, I think that's one of the things we've really enjoyed about the platform.
Great, thank you. And John, from you at Dignity, what are the what does the future look like for you, and how what are the thoughts on sort of the next thing for behavioral health?
Yeah.
So I think we might be having trouble hearing you. I'm going to ask the same question then of Anne. If you could give us some thoughts on sort of next steps for your organization and where you see the future of behavioral health and partnership with Amwell.
One of the areas that we are looking into is integrated behavioral health into our primary care practices. We do a lot of work with Medicare and ACOs, and there are behavioral health needs of those patients. And we don't have an ambulatory outpatient. I see us moving into, a more ambulatory setting, but across a region. So with the region, if we can do telehealth and provide those behavioral health ambulatory visits via telepsychiatry, I think we're going to be able to serve a lot of the population that we need to, and also utilize our resources. Having to have people drive to brick and mortar buildings and move psychiatrists from building to building, really, I think is no longer the future. So we're looking at that as a next step.
Yeah, I think you're so right that there's no going back to where we were. John, do we have you back?
I think so.
Okay, good. We'll give it a shot. So I don't think we got a chance to hear your answer. Yeah.
Yeah, the indistinguishability between care and being able to have rapid access, having a PCP be able to simply and very easily hit a button and have access to the right provider at the right time for the right reason, I think is going to be crucial. And the same thing for full-time psychiatric providers that may need the equal medical component to help support care, especially for the outpatient setting. So integrating PCP services with telehealth, I think, is going to be amazing. And then following high quality data for patient outcome based metrics.
Wonderful. Well, Katie, Jana, John, Anne, thank you so much for joining us today. It's been we could go on for an hour and we wouldn't touch on all the important topics, but thank you for giving us a bit of a whirlwind tour of what you've been doing, and kudos to all of you. And we're so glad to have you as part of the Amwell community.
Thank you.
Thank you.
Thank you.